Welcome to the Health Catalyst podcast, brought to you by YPO. Here we talk about the business of health innovation, and I sit down with industry leaders who have been in the trenches. My goal is to share the lessons and provide practical and actionable advice to help you launch, grow, and scale your business. I am your host, Rodrigo Hutt. Hello, everyone, and welcome to the podcast. Today, my guest is Dr. Jessica Schlicher. Jessica is the Chief Medical Officer at Providence, Chief Medical Officer of Digital Health at Providence, and also she's the head of content at MedPearl. MedPearl is a platform that helps clinicians organize medical knowledge and patient data to improve clinical decision making. Jessica, thank you so much for joining us today, and welcome to the podcast.
Thanks so much, Rodrigo. Glad to be here.
I am very excited about this conversation today. I think the role of AI in clinical decision support, I think it's one of my favorite areas where I think we're going to see a lot of evolution and progress in the health industry. So I am very excited about this. So let's start just with with the first question, and if you can tell us a little bit about what is MedPearl and what's the core problem that you guys are solving?
Sure. MedPearl is a clinical decision engine that enables primary care providers to understand what a specialist would do if they were right on their shoulder. So when I need to send a patient to a specialist, I need to know the right specialist. I need to understand whether the patient needs surgery or not. And I need to be able to understand that very quickly. There's almost an infinite amount of medical knowledge that's published. But when I see a patient, I just need a little pearl of knowledge for that specific person. And I need to understand algorithmically the way that the specialist would think about that problem, to understand what labs and tests and imaging mean that they need surgery, and what labs and imaging and evaluation that I can do mean that they can stay with me and stay within their primary care team. So MedPearl seeks to algorithmatize the brain of the physician with an augmentation with AI, and has actually achieved some great results, which I'm sure you're going to ask me about.
Absolutely. Oh, absolutely. So you mentioned something very important, and I think that when I think about doctors, I think about heroes, and I think that doctors are my heroes in many ways, because they have spent years learning about human biology, learning about medicine to help people's lives. And yet there is I can't even imagine how much health information, medical information, patient data it's out there. It's almost overwhelming, and I've heard this before, that medical knowledge doubles every 3 months or so. So if that's true, then there is a problem, which is information overload. And also, we know that doctors are not perfect. Doctors are human, and sometimes they don't even agree on a diagnosis or a treatment plan. So how do you see a platform like MedPearl helping clinicians manage the overwhelming amount of information and make better clinical decisions?
Well, patients come to us with undifferentiated suffering, and by that I mean something is impacting their quality of life. And we spend a lot of time in areas of uncertainty, as you mentioned. We also know that in medical school, where there's a common saying that half of what you're taught is wrong, it's your job to figure out which half. And in the context of medical knowledge doubling every 3 months, and the fact that a patient's chart has over 300,000 pieces of relevant data in it, how can we make the best decisions when the right decision may have changed since we were trained or since we read the guideline, right? So we need a tool that can allow us to understand the very best medical evidence in 2 minutes or less. And that's what MedPearl does. It has a layer of AI that enables you to put in what the patient actually said. And then it will navigate you to the algorithms that are created and governed by human physicians that are relevant to that patient. So it allows you to identify what you're not aware that you're missing, which is the place we make mistakes, to your point.
Right. No, that yes. And can you walk us through an example, like just pick a hypothetical example of someone coming to you as a physician. I would imagine that the first touch point would be a primary care physician or a family physician, or maybe urgent care if it's an urgency. Uh, can you walk us through an example, and so that we can understand how you would use a tool like MedPearl?
Sure. I had a patient about a year ago who came in with hearing loss on one side that day, just couldn't hear. I'd never seen it before. Pretty sure it was an emergency. The emergency department was overflowing. That wasn't an option. And I had no one on call to ask what to do. So I went into MedPearl and looked up hearing loss. And by clicking 4 buttons, I was able to follow the ear, nose, and throat specialist algorithm to know what the emergency was called and exactly what to do. You think about, I have to know as a family doctor, birth to death, what to do no matter what walks in, right? No matter who walks in with what problem is what I should say. And it can feel very overwhelming. So for that specific patient, I learned it was called acute unilateral sensory neural hearing loss. And he needed to be seen by a specialist within 3 days, and I knew what medication to start him on. The difference is I would have eventually figured out what med to put him on, but I wasn't sure exactly what to call it or how quickly he needed to be seen. The next day at 8:30 in the morning, I told the patient, you and I are going to get on the phone. We're not going to get off until you have an appointment with the specialist. So we did that, and when I called the specialist office and I knew what to call the problem, and knew what timeline for follow-up to insist on, they said, oh, of course. Anytime we get called with that, we're supposed to see them today. So patient got in, had an injection into his ear, and texted me after that saying he had recovered all of his hearing, and that the otolaryngologist said this is the only time in his career he had seen someone quickly enough to fix this problem. Usually when patients get to him, it's been 6 months and their hearing loss is permanent. For this patient, he would have lost his job. So the power to know the right thing to do in a sea of overwhelming options is really exciting. And it's why we say that MedPearl's mission is to restore the joy in caring for people. Because at its heart, caring for people really is joyful. And it's even more so when you know exactly the right thing to do.
That's an amazing story. Thank you for sharing it. My follow-up question is, like, how would you deal with this same case and this situation if you didn't have MedPearl? How would you have approached the same situation?
Yeah, that's an interesting question. Well, I would have looked up the ear, nose, and throat guideline for unilateral hearing loss, and it's 57 pages, by the way. And I would have tried to figure it out. I
Yeah,
would have tried
probably
to figure it out. And I
taking
would
your
have put in a
number and
referral, and the patient would have been seen at some point in the future. And if I didn't know to insist on 72 hours, his hearing loss would have been permanent, unfortunately.
yeah,
So the best information in the world is somewhere. It's just not everywhere. And it's certainly not always in my brain. And I think as physicians, we all realize that we're not perfect. I remember one of my teachers in med school saying, only angels should do this job, and there aren't any. So read a lot, was basically his answer, like, keep reading, keep learning. But the amount that we need to know to serve people well is enormous. And we can keep learning, but having checklists and simple algorithms that are curated by the best in the business in every specialty in one place, and then having the patient's data curated next to that decision tree, which is what we do in MedPearl, then I don't have to comb through the chart. I don't have to dig through it and figure out which data point. We had a physician, a neurologist actually, who works with me, who was using MedPearl for a patient in the hospital. He pulled up the patient's chart, pulled up MedPearl, and the first thing he saw, MedPearl pointed out, you missed a severely low B12. And a low B12 level can cause some pretty severe permanent neurologic problems. But the patient had already been in the hospital for a week. So he figured it had been done and was normal. How are we going to curate 300,000 pieces of patient data in a way that we would do if we were calm and unpressured for time and had the specialist right on our shoulder? That's what we're doing.
Yeah, yeah, I love it. I love it. And how, in the previous example with the hearing problem that you shared, I would imagine that if you're someone that knows what's going on in that space, you could tap into the national guidelines of that particular specialty and see what people recommend. But my question is, like, sometimes those guidelines are not perfect because they are based on the opinions of a few doctors that happen to be in that medical association, that based on some medical clinical trials, if there are any clinical trials, they make some decisions and make recommendations. So I guess my question is, how does MedPearl go beyond some of the literature to make sure that you are incorporating and taking into account all the vast amount of clinical, medical, patient data information, and curate a summary or specific guidelines and a course of action at that particular point in time? I guess that my question is, where are you getting all of your information, and how do you make sure that it's truly comprehensive?
Such a good question. Such a fun question, too. We start with the Specialty Society guidelines, but we have some AI tooling that allows us to find newer studies. There are a couple that I really like. Of course, anytime we use AI to identify any fact that we're going to rely on, we're going to go to the primary source and confirm that that fact actually exists and is true. So, yeah, I mean, it's very challenging to do. I think to your point, the specialty guidelines can be right, but sometimes not correct. And I'll explain what I mean. For 7 years, I was the medical director of a free clinic. You can give me all the guidelines you want, but most of those patients had no transportation to do labs and no financing to get medication. So you have to make it work. What are you going to do when you can't have all of the data that you want or all the imaging that you want, and the patient can't afford the first or second line medication? So MedPearl is not just the guideline, but the wisdom of what practicing doctors do in those situations, which we face all the time. You know, we can't just follow a cookbook for people. But in my 17 years of being a doctor, I've had lots of challenges and made lots of mistakes and learned lots of things. So what if we could curate that down into the hard-won learnings of our patients and our clinicians across the entire ecosystem and add those things? Like, for example, in our CBC algorithm, so if a patient has a very low white count, it's very concerning. It might be cancer, right? Many of these patients get referred to cancer doctors. There's actually a little known genetic variant that can occur in people of Middle Eastern origin, that if their white count's slightly low, but it's been stable for a certain amount of time, for several years, it's actually called benign ethnic neutropenia, and it's not cancer, and they don't need to be referred. So there's a little piece of learning that without it, hundreds and hundreds of people get referred to the cancer doctor thinking they have cancer, when actually there's this piece of learning that we need to distribute across the entire medical community. And there are many things like that. As we learn more, right? How do we change our practice? I know Atul Gawande, checklist manifesto, he would say that in the airline industry, it only takes a matter of months for a lesson learned from a crash or a near miss to be spread throughout the entire community of aviation. But in medicine, we've generally not had tools to make that possible, right? So with MedPearl, when the COVID guidelines changed or the treatment for heart failure changes, we have a completely no-code platform where the physician can go in and change that like today. And that's the difference. And then it's live across the entire ecosystem all at once. Instead of getting an email like I did during COVID that said, some stuff has changed. Here's an email with 15 links in it. Please review it and change your practice. No, I can go to MedPearl to the COVID algorithm, ask my specific question, and I know I have the most up-to-date information because Ron Dworkin, who's an infectious disease specialist, is obsessed with keeping that up to date, as is the rest of our core content team of 14 physicians. So I can be confident that I'm doing the right thing for my patient, and that's really where the magic of it is.
Yeah, absolutely, absolutely. It's super helpful. And would you say that MedPearl would be, it works kind of the same as ChatGPT in the sense that the magic happens when you know how to prompt, the chat thing, and in the sense
Mm,
that because you may have a patient with certain characteristics, with this hearing disorder, you go into MedPearl, you type that, and then you get some information. But sometimes, as you've mentioned before, maybe the patient doesn't have the resources to do blood work or to go to a hospital, and then you have to adapt. So, can you keep on prompting MedPearl to get tailored, personalized uh, responses or tailored information for that specific case? So I guess that, kind of the same way as how ChatGPT works for other use cases.
well, it's interesting because ChatGPT is just telling you mathematically what the most probable next word is. It doesn't actually think. I play with ChatGPT and Claude and Perplexity and all of those frequently because I'm a huge enthusiast and I think they're going to change a lot of what we do. But I wouldn't rely on them yet. And the reason is they're not supervised. There's no human in the loop. There's no curation. So if I'm going to make a decision that will impact a patient's life, it needs to be curated and checked with primary sources, right? I've asked ChatGPT I've actually tried, and it's a fun thing to try. You can go and put in what a patient would actually say. I feel anxious and I have left toe pain and my hair is thinning and I'm so worried because I'm a caregiver for my grandmother. And what people actually say, they're humans, it turns out, and it doesn't fit into a box very well. It's good for certain things, but I think when it comes to high stakes clinical decision making, even the greatest leaders in the field would say it's not ready yet.
It's not
Because it
ready.
doesn't actually give you the wisdom that's gleaned from years of hard-won knowledge. It can do a
So,
lot of things. I mean, it helps me do a lot of my administrative work, and I absolutely love it. But if I'm going to use it to care for a human, it's going to have to be right 100% of the time. Yeah.
so you have to go. Someone at MedPearl has to manually curate and approve and make sure that you have all the right sources of information, and also making sure that the algorithms are working properly. Is that correct,
Yeah,
or how?
so we don't use AI to write content, and there's a bunch of reasons why. There are at least 10 different sources of bias that we don't have a great way to mitigate. And again, I've really tried, but it's not that useful yet. I hope someday it will get there. But if you say, for example, what is the right treatment of an inflamed gallbladder? ChatGPT can tell you exactly that answer. But if you say, what should I do next for a 23-year-old woman who's already had 4 abdominal surgeries, who cares about these things and needs these things to happen, is this gallbladder the source of her problem? ChatGPT can't tell you that, right? That comes to judgment. And that's why in the course of creating a MedPearl algorithm, we have the basic information there, but then we actually incorporate the way that doctors actually make decisions, the best ones. And it's not, it has to take into account the humanness of the patient, right? So for example, if a patient is going through menopause and has cancer, has had a history of breast cancer responsive to hormones, but has certain symptoms and has certain priorities in her life, the best doctors are going to make decisions based on her priorities, not based on just A plus B equals C medical treatment. That doesn't work for humans, right? So we're trying to actually put the way that the best doctors think into the algorithm on top of what the guidelines might say. And we put in things like health, limited resources, like we were talking about. And if you can't do any of that, here's the approach. Or health equity. And by the way, these guidelines don't apply very well to this group. Think about it differently. That's the thing that isn't out there right now that I think is really exciting about what we're getting to do.
But help me understand. So AI, you are using a layer of AI for MedPearl that helps you access, summarize, etc. The vast amounts of data that it's out there. But then you have your own proprietary kind of algorithm that takes into account how doctors would think or would use that information. But how do you do that? If that's correct, then how do you do that at scale?
We only use, right now, we use AI for two things. We use it for search, natural language processing for search. So you can put in what the patient says, it maps you to the correct algorithms. The algorithms themselves are actually created by humans. And then we also use a layer of AI for identifying primary sources quickly and allowing that literature search to be more robust. But the literature on the use of AI in medicine right now actually does not support creating decision-making algorithms completely with an AI. It just doesn't support it. I mean, if you look at best practices guidelines for the use of AI, it's not there yet. It's not reliable enough. AI doesn't actually think algorithmically, right? It's only predicting what the next word is. So we have the search function and the identifying primary sources function, and that helps us get faster in an unbiased way. But when it comes to creating the algorithms, those are created and curated by physicians themselves.
Okay, so you have like a special committee that would get together and then create those algorithms based on therapeutic areas or domains, or how are you organizing MedPearl? Because I thought initially that MedPearl was considered a generalist AI type of tool, but maybe this is more of a specialized platform, if you will. Is that accurate to say?
So we have a core team of 14 physicians whose part or all of their job is to create and curate this information. So it's not just a committee, it's actually their job as part of the MedPearl company. And we've been able to show that it actually improves the operations of the entire health system. I would say that it is designed for generalists like me, family docs. It's very interesting because Providence has 4,000 monthly active users. We have far less than that primary care docs. So what we're finding is that the specialists, once they create the algorithm, they love it so much that it makes their job easier and they keep using it with patients. You can turn the screen to the patient and say like, okay, the aneurysm in your chest is this size and this is how we're going to treat it and here's why. And the algorithm helps them explain exactly how they're doing that. It's made for generalists, but it's actually being used by hospitalists and ER docs and neurologists and psychiatrists, just organic growth-wise, which is pretty cool because any digital health company can tell you that adoption is very difficult. But what I like to say is more than 300 doctors helped give birth to MedPearl. And when you give birth to the baby, you don't have to force a person to adopt it. So there's been organic adoption and growth and love for the product across Providence, which is really cool. And was not because of me. Our founder, Dr. Evie Cunningham, was doing this for several years before I got here. So
yeah, amazing. This is really good. Let's talk about your customers and your users. Like who is your customers? Who's your customer, and are your users different than your customers?
Well, I like to think of everyone as my customer. So we could get into that, but I don't think that's what you're asking. We were developed inside of Providence, so our customers include the medical group, all of the physicians. I believe there's 12,000 physicians and APPs in Providence or affiliated with Providence. That's where it was incubated and grown and continues to be used, 4,000 users a month. recurrently. In fact, of all people who try it, 75% keep using it. We have several health systems that are going live in the next 3 months that are external to Providence, as well as some other kind of innovation development partners that I know I can't tell you, but they're very exciting. And we think the moon's the limit. I mean, we really are excited about spreading this across the whole medical community, sort of a democratization of the best possible medical knowledge.
Yeah, that's right. That's right. So you, if I understand correctly, your users are, doctors, physicians, and but then, if this is a company and you are planning on scaling this as a business, then I would imagine that hospitals, health systems, clinics, providers, any kind of provider could potentially be your customer. Is that correct?
Yes, we have several enterprise contracts already with many more in the pipeline, so we're very excited about that. The important part is for us to come across, though, um, we have to come across in the way that the platform was created, which was by clinicians for clinicians, rather than another piece of technology that someone who doesn't see patients anymore thought was important. So
Right.
we're working really hard to make sure that that love letter comes across, because it really is meant to restore joy in caring for people. Yeah.
Yeah, that makes sense. Building a product from the inside out makes total sense, versus just building something out of nowhere. Let me move on, and let's talk about you know clinical effectiveness, or measurable outcomes. And I wanted to ask about success. Like, how do you measure success at MedPearl? What are some of the key metrics that you would focus on when you talk to your customers and you want to demonstrate the impact of MedPearl to your customers or potential customers? Like, are you talking about patient outcomes? Are you talking about cost reduction, clinical efficiency? What are some of the most important metrics that drive MedPearl's success?
Sure. Well, as you know, all health systems are under a lot of pressure these days in terms of where they put their precious capital for projects. So MedPearl has had to be very rigorous about the way we measure outcomes. We were recently published in the New England Journal of Medicine Catalyst with our outcomes, and I would say there are the clinical outcomes, which are compelling, and then there is the CFO analysis, which is also compelling, and really both sides need to be strong, right? Excuse me. From a clinical point of view, we know, for example, that clinicians report, and we can measure, that 72% of the time when they use MedPearl, they learned something they did not know that changed their patient's care plan. 72%. We also know that 20% of the time, the clinician used MedPearl and said, actually, I don't need to refer this patient at all. I can keep ownership of this patient's care. An additional 20% of the time, the clinician who was going to refer the patient sends them to a completely different specialist based on the information, or with a different level of urgency, just like in the patient I saw with hearing loss. So we're seeing clinical outcomes improve, a variety of other things. For example, clinicians improve. We've been able to show a statistically significant improvement in Suboxone prescribing for clinicians who are treating patients with opioid addiction. That's been notoriously hard to increase because Suboxone was under the X waiver for so many years, and there was so much need for a special license. So we've really had to shift our medical practice, and it's helping with that as well. A bunch of other things, but I would shift also to the financial outcomes, which are very, very important. So as you know, health systems, generally large health systems, have an outpatient clinic-based business and a hospital-based business. And they tend to invest in the outpatient business and then capture and help people in the hospitals on the other side of that. The only way that works is if the right referrals are going from primary to specialty care, so that surgeons are only seeing patients who need surgery. It's the only way those operations can be improved. So, okay, it's not the only way, but it's a very, very important way that those operations need to be improved. Otherwise, you have a funnel that's full of patients. Some of them need surgery, Most of them don't. And how do we get the patients who are sickest through the funnel, right? Because when a patient is waiting to be seen by a specialist, their utilization of the emergency department and the hospital are 8.7 times higher than a person not waiting for a referral. So if a person has to wait 6 months, their cost of care is much higher, not to mention the preventable human suffering if they had appropriate access in the moment when they needed it most, right? So that's why we developed it, and that's what we're working really hard on. But to your point, cost avoidance and improved operations of large health systems, we've had to prove all of that in order to earn the continued development of MedPearl inside Providence.
Yeah, I would imagine. Yeah, that's what I imagined. It's all of the above. It's not only one metric. And how do you charge your customers? I mean, is it by license? Is it like a software as a service type of business? Um, tell us a little bit about that.
Yeah, so we have a SaaS model and it's tiered pricing based on the size of the user group, right? So we're going to charge it in a very fair way, in a way that's affordable for health systems. I would be misspeaking if I didn't have our chief commercialization officer answer the details of that. But yeah, similar to other SaaS type companies. And then the patient data contextualization is the other really exciting part of that, that within the EHR, MedPearl is going to curate the data that you need to see alongside the algorithm. And so that changes the pricing a little bit, not much, but if that work is necessary, we're also ready to do that tech lift as well.
All right. Okay. Sounds good. Let me ask you another question about where health AI is going. And one of the questions that I keep pondering, it's about how do you see the role of AI in democratizing medical knowledge, and in particular, if tools like MedPearl are emerging and are becoming very effective, then do you really envision a future where all doctors have the same level of expertise? So today, some doctors could have better reputation than others based on their experience, their expertise, and so on. Do you think that AI and health AI tools such as MedPearl will democratize, medical knowledge, and every doctor would be kind of on the same level? If that.
Such an interesting question. The first thing that I read in medical school a long time ago now was a study that was done where about 20,000 patients came in and they recorded whatever that problem was. And then a month later, they asked them, has it improved? And it was measured. Did we do surgery? Did we prescribe medication? Did we send them to a specialist? What did we do, right? The only thing in a huge group of patients that's related to a patient saying that they feel better at day 30, statistically, for all of them, is whether the doctor looked them in the eye and heard what they were actually saying. So that comes to the point of like the differentiator for a great doctor is not necessarily the ability to vomit out the right answer, the right medical answer. It's a doctor that has the judgment and the discernment and the connection at a human level to know the right thing to do for that individual human and their values. So I don't think doctors will ever be equal at that. And in the end, what has value is what the customer would actually pay for. And that's feeling better. And the feeling better comes from the discernment, which we learned from many, many, many years of seeing patients and doing it right and doing it wrong. So I don't think a new doctor is ever going to be as good as the doctor who knows how to sit down and really hear what you care about. It takes a long time to learn that.
That's a very interesting answer. Let me push back a little bit, and I it would make sense. It makes sense what you're saying if you are comparing a younger doctor with a more senior slash experienced doctor. But what if you're talking about two doctors that have been practicing medicine for the last 25 years, 30 years, and there is a difference in medical knowledge? They have the same level of expertise, but they both have the same level of empathy and curiosity towards their patients, and but now they have MedPearl. So in that way, there is a future where all physicians, or at least most physicians that really care about their patients, could potentially be treating and serving their patients at the same level of expertise and impact. Is that fair to say?
You
It
know,
might not be with a younger doctor, because that younger doctor,
mhm.
I know that they might not have the same level of expertise and empathy and many other, not necessarily the only IQ, but also EQ and many other things that go into, connecting and relating to a patient and understanding the patient's needs. I don't know if I'm making sense with my question.
Yeah, I mean, I think I'm understanding. Correct me if not. Back to my hearing loss example, the day in which every urgent care doc knows the right thing to do for that patient is a good day for us, right?
Yeah.
Absolutely.
Yeah.
And the reason why we have things like peer review, where doctors get together at 6 in the morning and review mistakes that were made, is to try to disseminate those hard-won learnings across the entire medical community. That's what something like MedPearl can do.
Yeah.
Um, so absolutely. But I would say that there will always be humans involved. And so the quality of care really depends upon the patient's perception. I mean, you have to do the right care, that's a given, and that's what we're working on. But for a human to feel they were actually cared for,
Yeah.
that requires you to look them in the eye and hear what they're saying. And the beauty of it is that MedPearl also does that, because if I know the right thing to do for you, then I actually can hear what you're saying instead of pawing through a 100-page PDF trying to desperately figure out what mistake I'm trying to avoid, right? If we can curate the medical knowledge and the medical data, then there's more time to make the connection so we make the right decision, not just medically, but for the human being, right?
Absolutely. I love that. I think that's a very good summary of my question. But yeah, I think ultimately, a platform like MedPro, it's democratizing medical knowledge. It's helping clinicians to make better clinical decisions, and that will allow them to spend more quality time to care for their patients, and spend time connecting at a human level. I love that. Yeah, maybe you can get your marketing materials and messages from that.
You know what matters, Rodrigo? I think you made me think of a friend of mine, and her wife was dying last year. And I had the opportunity to help walk her home. And what she tells now about that story is that I emptied the urine bag when she was on hospice. And the hospice nurse came and said, "She's not urinating." And my friend said, "Oh no, my doctor friend came and she emptied that urine bag and she did the personal care and she took care of it." And that's what she talks about, not the dose of morphine or the suction thing that I tried to fashion out of some things she had in her house. She doesn't talk about anything that I would think was medically smart. She talks about the thing that as a human being, I was privileged to be able to do for her,
Yeah,
right?
yeah, that's beautiful. Thank you for sharing that. Uh, I have a question about regulation. And how do you see the regulatory landscape evolving in the health AI space, and in particularly around patient safety? I mean, you just mentioned that AI won't do the whole job, at least as of now.
Mm-hmm.
Um, but I wonder that if there is, if we are, you know, accessing different sources of information, some might have higher validity than others. And then there is a group of physicians that are building these algorithms. Um, Something could potentially go wrong uh, in a diagnosis or a recommendation, or a treatment plan. So, you know, on the one hand, like, what kind of regulatory, you know, issues are you facing or will potentially face with the AI adoption? And in particularly, how are you mitigating potential patient safety concerns?
Hmm. Such a prescient point and such an important point. We've been really thoughtful about how we use AI. So it's very, very important that the biases of AI are taken into consideration. Of course, the biases of AI reflect the biases of the human brain as well. So we have to be aware of both. I like to call it algorithmovigilance. I don't think that's a real word, but algorithmovigilance meaning like every time we're actually branching an algorithm, making a decision, how do we know that? Have we confirmed and read the most up-to-date primary sources, not summaries from an AI, primary studies that confirm that that's the right way of thinking? Because it turns out with the use of any AI that there are still humans involved, right? So when I read the studies of physicians who are working with AI, it's very interesting. In general, about a third of physicians will say, I'm not using this at all because there's an AI and I don't trust it. Because we have been trained that no error is acceptable, right? So they won't use it at all. About another third might take the AI's recommendation without appropriately questioning it. And in some of those cases, the judgment actually gets worse. And then in about 40% or another third-ish, there's what we call appropriate AI interrogation procedures, meaning that I make what I think is right before I ask the AI, right? So that I'm not biased by what the AI puts out. And I ask myself, how does the AI work that it's making this recommendation, making this logical conclusion? And I take extra time. It actually takes longer to thoughtfully incorporate the recommendation of the AI. But in all the studies I've read, there's actually no evidence yet that the use of AI actually makes medicine better. Not yet, because there's still a human interacting with it, right? So we can undertrust it, we can overtrust it, or we can appropriately interrogate it. So we will push the edges of what it can do, but we will never do something that puts our patients at risk, which requires human in the loop when it comes to creating algorithms. And I think we're well aligned with what's known about the biases of the AIs that are on the market now. I hope AI gets to a level of generalized logic. I really hope. That would be great. Why shouldn't every person know how to treat HIV or know whether a laceration needs sutures? Or, I mean, they should, right? Like we should get to that future, but we're not there yet. So as long as we're not there yet, there's still work to do. And I'm just super excited to get to be a part of it.
Absolutely, I am very excited about this field. Absolutely, and I think we're going to see huge advancements over the next 5 years. I'm sure of that. This is my final question before we wrap up this super interesting conversation. You've mentioned about technology adoption, that it hasn't been an issue uh, within Providence because you developed the product taking clinicians into account. It was developed by clinicians for clinicians. I love that slogan, if you will. But if you go to a new health system, or new customer, some people that are outside of Providence, like, historically, as you've mentioned, doctors, clinicians can be skeptical. They will not adopt it just because you tell them tell them to do it. So I'm curious about, like, how has the adoption been in at other hospitals or other health systems, and in particular, what strategies have you found most effective in building trust among physicians outside of Providence?
Yeah, that's a great question. Often health systems already have certain pathways that they've developed for high priority things like heart failure or neonatal high bilirubin, things like that. So when we're going to our initial pilot group with the health system, we just put our algorithm right next to what they have, and we go down it and we're very transparent about it. And what the answer we get is, Well, those agree, or there's a slight difference, and we actually have the ability to put an organization specific banner or envelope around information. So if there's a specific type of specialist that they do or don't want a patient routed, we can change that specifically for the customer. But we know we're going to have to earn trust everywhere we go. But I'm real comfortable with that. Because every clinician practicing knows the problem. We're not giving them a problem that they don't have, right? I mean, when I work urgent care shifts, half my time is wasted just typing and clicking boxes. They all
I
know that. And so I think what I said in our last go live was, if you could just, I beg you to suspend judgment for the next 5 minutes, because this is a love letter to you. And, if they're family doctors, they get me. It sounds like unicorns and rainbows to a urologist, but if they're family docs, they get it. And we'll say, okay, what kind of problem is really complicated for you? And they might say heart failure or diabetes or PTSD, right? What do you want to get better at in the next 5 minutes? Show them what we have. And that response we usually get, especially from healthcare executives, is, hold on. Don't show this to my doctors, because I have to make sure I have budget for it. Because once you show it to them, I'm going to have to get it for them, because they can see that it makes it easier for them. I'm a believer because I use it in my clinical practice, and it's made my job easier, right? It's made me be able to be, like you say at the beginning, a superhero, maybe in just a small way.
a super doctor, that's for sure. So do you envision some level of customization of the tool depending on each customer? And
Yep.
and if that's the case, if you do too much customization, then that could become very expensive for MedPearl as a company in terms of cost to serve and product development and so on, which will impact pricing and therefore adoption. Then on the other hand, if you already have algorithms based on what the doctors that developed MedPearl suggest, then that would mean that every hospital or provider could potentially be using MedPearl in different ways, and hence different treatment plans or recommendations to patients.
Our core library, actually, we haven't gotten feedback that core information or thought algorithm needs to change. The customization tends to be things like, the metric we're trying to impact this year is high blood pressure, and here is our standard. So they want that added in a banner. That's very easy to do. It's very scalable. We had a customer who was interested in having our tool automatically write the annual wellness visit with all of the elements that are needed to bill for that correctly. So we got that back to him in a week and a half. So I think it's just most of what people will want is the existing content. And then certainly we customize, because again, the value is dictated by what the customer actually wants to pay for. And we are able to create these things very agilely. And that's not a word either. I think now I've given you 2 words that don't exist.
But I get it. I absolutely get it. I think this is great. I am very excited about MedPearl. I met Dr. Evie Cunningham a few months ago at a health technology event, and I was fascinated by her story and by MedPearl. So I want to thank you for your time. I want to wish MedPearl and the entire MedPearl team all the best of luck and in this new endeavor. If I were a physician, I would definitely be using a tool like MedPearl because to me it's a no-brainer. Doctors are great and I admire them. But if I think there is a potential to become super doctors, and I like to say that instead of saying AI, artificial intelligence, I prefer to say amplified intelligence, and you can do much better things as a physician if you use these new tools. And the most important thing, as you mentioned earlier, This will free time. It will give you time to spend quality time to connect with human beings that are your patients. So I want to thank you, Jessica, for your time again. And I want to thank everyone for watching and listening today. So thanks, and until the next time.
Thanks so much. Great to see you.
Thank you, Jessica. Bye.